of trauma and things like that. And I think there's a good reason why, and hopefully by the end of this presentation, you'll kind of understand where that disconnect may be. So we'll be talking about deconstructing pain, trauma in your brain. I really don't have any disclosures. I'm sort of semi-retired from this kind of aspect. We can talk about that more after the end, but I've done some education and training. I've done some consulting work, did predominantly training of clinicians of all different types, physicians, nurse practitioners, nurses, physical therapists, occupational therapists, social workers. So kind of the gamut of people who are working with others in this healthcare system. I'm going to kind of skip over those because that's more important for a formal kind of CME talk. But this is me. For those that you don't know me, I am Dr. Kevin Cuccaro, and the whole thing on the left side of the screen kind of talks about my background. And if you kind of go through the regular medical system and you become a pain specialist, I have done all that training. I did my anesthesiology, which is sort of the foundation in Chicago. I did my fellowship in pain medicine at the University of Michigan. I was in the military at Naval Medical Center San Diego, and very quickly was the associate program director there of the fellowship program. And that's a way to say is we do a lot of, or I should say I did, and they do, lots and lots and lots of injections and interventions. That was sort of the focus, is if we could find, quote unquote, the pain generator, and then we can somehow anesthetize it or burn it or block it or do something, then we would somehow produce these results in pain. We'd help people. And that's the whole reason most of us have gone into medicine, and the reason most of us go into healthcare is we want to help people get better. Now, why does that definition of better, or why do I have better underlined, is because the other part about this is I've learned that better means different things to different people. And better to me means this, that if someone comes in with a problem, we address that problem in such a way that they should not have to see us again and again, and they can get back to living their life in the way that they want to. If you're seeing somebody every 2 weeks, 3 weeks, 4 weeks, 5 weeks, over and over and over again, and they're really not improving to the point where they can go out and live their life, that's not better to me. And I have run into people who think that that's okay. But I just want to clarify, better to me is really you're getting functional, you're going out and you're seeing your family, and you are, really the job of healthcare is to treat people in such a way that if all goes perfectly well, we would all be out of jobs because there would be no pain and suffering in this world. Obviously, that is not the case. We will never run out of jobs, but really ideally we should be reducing all of that suffering, disease, and trauma such that the majority of people could get out and get back to living their life again. And I wasn't seeing that when I was treating pain. I had, people come into my office and they would say, "Oh, I feel so much better, Dr. Cuccaro, off that injection. But now my shoulder hurts, or my knee hurts, or my neck hurts." And then we do this kind of game of whack-a-mole. And in the military, we worked in this clinic with 6 other fellowship trained pain specialists. The reason that becomes important is because you can't hide your results. If someone says they're better, and then I see their patient subsequently, I get a really good idea of what their definition of better is. And a lot of times what people say is better is not getting people out into back and living their lives again. So I thought it was a Navy problem. When I left the Navy, I came up to Oregon and to Corvallis, and I joined a medical group here. I was the solo pain specialist. I was, oh yes, I can treat people just the perfect way because, all doctors were pretty arrogant. We think we're doing everything perfectly, and everybody else was the problem. And very quickly, within 6 to 8 months, I noticed the same thing. I would come in and I would do everything. I was very evidence-based approach in the way I practiced. I didn't just willy-nilly inject people. I tried to find, what was the right indication and do all these definitions of causes. And very quickly, I found that my results were no different. That again, people would come into my office and say, "Hey, Dr. Cuccaro, I feel better." But when you look in their chart, if I had done an injection in their back, and a month after that, they're getting another injection in their shoulder, and a month after that, they're getting an injection in their knee, and then we're going back to the back again. And we're just doing this kind of whack-a-mole game. And I'm not seeing the medications go down, and I'm not seeing them, see less and less specialists. In fact, what I would see is seeing more and more and more and more specialists. And it became very frustrating because I couldn't blame anybody else, right? It was just me in this clinic. I couldn't say, "Oh, it was that guy's fault," and it was my buddy over there who trained differently than me. And then I decided, well, okay, if I've been in the system with a bunch of people and we kind of practiced together and I saw these results. And then I'm off by myself and I'm doing things what I thought was the ideal method, and I'm still getting the same results. I better go back to the literature and research what the literature says. And when I took a moment and looked at the data with one of the most important mind shifts I've ever had in my life, which is, if the data doesn't confirm your biases, trust the data first and then see why. I started seeing that this whole entire profession I was in, the evidence that we had to support what we did was between slim and none. And that was a personal crisis, a crisis of my profession. And then I'm like, well, if what we do doesn't work, well, maybe then fundamentally we don't understand pain. Because if you're treating this thing over and over again and you're not getting the results you want, there's either two things. One, you're treating it inappropriately, or two, you don't know what you're treating. You don't understand it very well, or more likely both. You don't know what you're treating, and because you don't understand it very well, you're treating it inappropriately. So I went back and actually then studied the science of pain, and that completely changed not only my practice, but my life forever. I have not touched a needle since 2013. I have not done any sort of those interventions. I've been much more involved with teaching others because of the problems I saw with that profession. And it really comes down to misunderstanding pain. With that, I do consider myself a pain specialist now, not an injectionist. And I did all this work before with healthcare systems, patient-centered primary care homes. I was on the state commission for a while, served as the vice chair there. I've been on a number of different regional and state task forces. And now, though, I've kind of stepped back quite a bit. I got a little bit of fatigue when it comes to sort of the work that's involved with this. But it has affected me very, very personally, meaning the way my life is now, I would never go back to not knowing what I know now, because as we get older and our bodies become, say, less physical resilient, it has really impacted how I live my life in such a way. I don't have a lot of what I would call pain, despite being extraordinarily active and despite having lots and lots of sensations in my body. And we'll kind of talk about why that may be later on. So it's a huge bit of impact. And then our community here, we actually have a small organization of, I hate the word patients because it means one who suffers, but there were prior patients with pain, and they kind of have been involved with some of the people I've worked with in the Valley and have really sort of transformed their lives and experiences. And they have a little organization called the Oregon Pain Science Alliance. And so our little pocket community here in Oregon actually has some of the most pain aware and pain knowledgeable kind of lay people that I've ever seen anywhere. And it's kind of exciting. And to see these little kind of small pockets in the community having some transformation is profoundly exciting when we kind of look at the overall picture. So what we're going to talk about today is, why do we hurt? Right? We all experience pain, but why do we experience it? What is the purpose? Because there is a purpose. And then how do we hurt is going to talk about, well, how does that actually operate? If we know and understand why we hurt, what that purpose is, we want to understand kind of the mechanism between the brain and the body that allow us to do that. What allows pain to do its job? And then we're going to talk about pain and trauma, which is probably something that you guys see quite a bit in your communities, particularly if you're doing work with the homeless, and why some of those comorbidities that we see are there and how they all overlap. And then we'll touch briefly, if we have time, on applications of safety and empowerment. So this gentleman, and because of this presentation format, I'm not going to ask you if you know exactly who he is, but Dr. Ignaz Semmelweis was a physician in the mid-1800s, kind of both a personal hero of mine as well as a cautionary tale. And Dr. Semmelweis was born in the golden age of dissection and practiced medicine pre-germ theory. And his very first job when he came out of his training was at I think the Austrian General Hospital on the maternity ward. And within his first month, 20% of the women that were admitted died. Now, childbirth back then, it still is dangerous, one of the top causes of death in childbearing women now, but back then it was extremely dangerous. But what he noticed was in the general hospital, there were two wings. There was the medical wing that was run by the physicians, the residents, and the medical students. And then there was the other wing that was run by the midwives. And they would alternate patients on different days. So say Monday, the physicians would admit the women that were coming in active labor. And on Tuesday, the midwives would. And what was really upsetting to Dr. Semmelweis was the fact that the death rates between the two wings were incredibly different, so much so that it was noticeable to him as a new physician. And the community actually recognized that there was big death rates, and the community themselves, if a woman was in active labor and she heard that the physicians were admitting the women that day, would often pretend like, oh, I'm not actually in labor right now. This is probably not, I can wait till tomorrow. It's not a big deal. And they were delivering babies in the streets rather than get admitted to the hospital. And this really upset Dr. Semmelweis because it doesn't make sense. How could you have two people, people get admitted to the same hospital with the same problem, that is childbirth, different days, different people admitting them, and completely different outcomes? And so he thought, well, let me actually try some interventions and see if I can change this. Again, this is pre-germ theory. So they would close the windows to stop the evil humors from coming in, and the women still died. They'd open the windows, maybe that let the evil humors come out, and the women still died. He thought maybe we're scaring the women to death because as a woman died, a priest would walk down the hallway ringing a bell. So they stopped the bell ringing and the women still died. And no matter what he did, the women still died until a tragedy occurred. Because this was the golden age of dissection. And what the physicians and medical students did between admissions and between births is they would go into the basement with the corpses of the people who died, and they would dissect them. And during one of these dissections, one of his friends cut his finger. And within a week, he developed symptoms that were identical to those of the women who died, something they called puerperal fever. And he subsequently died. And Dr. Semmelweis said, well, this is interesting. He died of symptoms that were identical to the women. Well, what do the midwives do between cases? And when he looked with the midwives, they deliver babies. And when they were done, they would go to their break rooms and they were knitting and they were drinking tea and talking to each other, while the physicians were going down dissecting corpses and kind of doing this on their aprons and going up and delivering babies. So he said, okay, let's introduce a hand washing regimen. And he didn't do it because of, again, they didn't understand germs, but their hands stunk. So he had a chloride lime solution. It was the only thing he could find that could make their hands not smell bad anymore. And when he introduced hand washing, the death rates plummeted, so much so that they had months on the physician side that there were no deaths. This is unheard of at the time. So Dr. Semmelweis then goes, women are dying. What we need to do is we have to wash our hands. And Dr. Semmelweis' colleagues said, what are you talking about? How dare you say that our hands are the same as a common field laborers? We're physicians. We're like second sons of aristocracy. This doesn't make any sense. This is insulting to us. Again, pre-germ theory. So they drove him out of the first hospital. He went to a second hospital. He duplicated his results again, and they drove him out of that one. He became increasingly more distressed at the number of maternal deaths that there were. And then after 20 years of this, he said, I've got to do something about Semmelweis. He keeps making a lot of noise. He said, why don't you, here, Ignaz, come with us. We're going to go look at an insane asylum, and we want your opinion on what this insane asylum is like. So they brought him there, and when he walked in the door, they locked it behind him, involuntarily committed him. And when he tried to walk out, the guards beat him, and 2 weeks later, he died of sepsis. So it was roughly 20 years later, the germ theory was introduced, and hand washing and hygienic practice was introduced to medicine. And really what this has to do with pain, and the reason I bring this up is because of these assumptions and misconceptions. Again, it was not that physicians at the time were horrible, awful people. It's that Dr. Semmelweis challenged these assumptions about what they did and who they were. And it was extraordinarily difficult to process because it didn't kind of align with what their pre-existing belief system was. And so these assumptions and misconceptions, rather than challenging them, they block them. And if something, again, doesn't make sense, like it doesn't in this situation, and what you tried doesn't work, In order to achieve a different outcome, what you need is different thinking. Different thinking. So the problem with pain and pain care is everybody experiences it universally. There's very, very few people who go to see their healthcare clinician to say, you know, I feel great. There's nothing wrong with me. In fact, the only people who do that are the ones that we say, you need to come in for an annual physical so we can try to find something wrong with you, right? Otherwise, you go in because there is pain or symptom. There's something that is driving you. There's some sort of distressful symptom that is driving you to seek what it may be and why it's there so that you can get better. It is the most common reason for Social Security disability. So 3 of the top 5 are back pain, neck pain, other musculoskeletal pain. The other 2 are anxiety and depression. And I want you to kind of keep that in the back of your mind. We spend huge amounts of money on the treatment of quote, pain, $600+ billion annually. And this is old data. This is probably 8-year data. I haven't looked up the most recent numbers, but it hasn't gone down. And then depending on who you talk to, the prevalence rate for chronic pain is between 11 and 40%. Now, 40% is a huge, huge, huge number. And so it seems to be more about 20% consistently when you kind of get away and have more of a standard definition for that. Now, what have we done for the treatment of pain? Well, we've done MRIs and X-rays. In a 10-year period, those increased over 300% for non-specific low back pain, where every single evidence-based guideline says you are not supposed to get imaging. In fact, we have been over-imaging things since 1970s, and we still do more and more. Procedures, the things that I used to do and was trained to do, have increased between 130% to over 1,000%, depending on the nature of the injection. And the more interventionalists that you have in a specific reason, the more injections that you have in that area on people. And lo and behold, you don't have any less experiences of pain there. In fact, the prevalence rates of pain seem to be a little bit higher. Surgeries for back pain, say back fusions, increased over 300% in 10 years. And actually complex fusions, ones that are doing anterior and posterior approaches where they flay you open and they kind of fuse the back segment and they flip you over and then cut you open in the front and then they fuse the anterior segment. Those increased over 1,500% in a 5-year time period, and was estimated at the time, that was about 10 years ago, that if that rate continued, it would bankrupt Medicare by 2030. Opioids for pain, and particularly for chronic pain, increased over 690% between 1996 and 2006. And then within another 10 years, they doubled. And that has kind of started to trend down, although I'm a little bit concerned that we're probably going to go back again because there's been this big revision of the of opioid prescribing. And in fact, I just looked at the most recent kind of trainings around that, and they're very close to what they were at the beginning of the opioid epidemic, which is somewhat concerning to me. Now, we did all this stuff. We looked at people trying to find sources of their pain. We poked them, trying to block those sources of pain. We did surgeries to fuse those sources of pain. And then when we didn't know what else to do, we prescribed opioids for their pain. And what did we get for this? Well, we actually have higher rates of disability due to pain than ever before, higher complication rates, including those procedures that I used to do that are often billed as, oh, these are less invasive and they're sparing. And in 2012, there was tainted steroids. So even if you did the procedure right, they injected a bunch of fungus in people's backs and gave them arachnoiditis. There's multiple surgeries. I have a surgical friend who is since retired now, would tell me he used to see people who came in, that you looked at the original imaging pre other surgery that they had, and the segments were normal and they were getting fused. And now they actually, because they were having post-surgical complications, because once you fuse a segment, you get increased degradation, and people's spines were actually collapsing and causing these huge scoliotic curves. He was a scoliosis surgeon. They were trying to do the kind of restorative work to get him to stand up again. But the original surgery should never have been done. And we're bankrupting healthcare. You know, anytime someone says that we need more money for healthcare, I say, no. We spend more on our healthcare system than anywhere else in the world. And it is not that we need more money. We need to look at what we're spending our money on. Because if we stopped paying money on garbage therapies, we'd have plenty of money for everything else. And we're not doing that. Now, from a patient standpoint, though, the thing that is pretty important to everybody who ever experiences pain is that we're not seeing improvements in self-reports. Despite spending all this money in doing all of these treatments and all these therapies and prescribing all these medications, we are not denting that number of prevalence rates. It's 20%, and it basically just holds steady decade after decade after decade. So if I was teaching my residents or if I was teaching medical students, the question is, if you are treating something and you're doing more and more treatment and you get the same outcome or worse outcomes after you treat it, what should you do? Stop. Right? I mean, it's common sense. You stop and you set it and you go, what is it that we're treating? Do we understand that we're treating? And then we treat it, and then we try to treat it appropriately. You know, we could try different interventions. We don't do the same things over and over and over and over and over again that we've been doing for at least 40 plus years now. And the way you have to do this is we actually have to think differently. And for me, what this means is if when I started actually doing a lot of teaching, I started kind of going into like educational theory. And if people think they understand a concept, guess what happens? They don't listen. And I started knowing this, recognizing this when I was going to pain conferences, and all these pain conferences. In fact, if you ever go to a pain conference outside of ours, Oregon Pain Summit, which will be in October, look at what the talks are on, because they'll call the summit the pain summit, but almost all the talks that they have, they're not about pain. They're about opioids, they're about addiction, they may be about trauma, but they're not actually talking about pain, what it is, why we hurt, how it works, what the evidence shows, what the science shows about pain. And until we start thinking differently, we are not going to see changes in how we treat it. So let's step all the way back then. And let's do this assumption of, let's pretend we don't understand pain. Right? Because we've all experienced pain. We typically think that we know what that means and how it works. But we don't go on a plane and experience flight and believe that we understand everything that's involved in that process. So what then is pain, and why do we hurt? What is the purpose? Why do we have this experience? So in live audience, what I used to do is I would flash these up one at a time, and I would have people raise their hands. Well, okay, this guy has got a huge big nail through his boot. Is he or is he not experiencing pain? And people like, well, yeah, obviously they're experiencing pain. Now, what I would do here, though, is if you got the guy with the 7-inch spike through his boot, that's a steel-toed boot, his foot was in the boot, and then you got the guy with a nail through his thumb, we could say, well, who has more pain? Who's experiencing more pain between these two individuals? Now, I kind of get upset when I even say it because it's so judgmental, and we're going to talk about why this does not work. But typically we'll say, oh, God, that guy with the big steel, they both have pain, but the guy with that nail through his boot probably is experiencing more pain. And yes, he was experiencing more pain based on how he was screaming. He was a 29-year-old builder, jumped off a low wall, hit the ground screaming. They saw that through his boot. Was taken by ambulance to the emergency department. In the emergency department, he got fentanyl and Versed, which is benzodiazepine, which is synergistic together. After they gave him that, they could touch the boot because before he was screaming too much. They got him calmed down. They cut the boot off, and they discovered that the nail was between his toes. And so I used to then say, well, okay, well, was he experiencing pain? And I had people say, well, no, he's not experiencing pain. I'm thinking, that's very interesting. He was screaming. He was writhing in pain. And they gave him opioids and a benzodiazepine that if you give to somebody that doesn't have all that sympathetic surge, he's not experiencing pain, what happens to him? They overdose and they go into respiratory depression. And that didn't happen. So what he was experiencing was a tremendous amount of pain, but what he didn't have was tissue damage. So no tissue damage, horrible pain. And the image on the right-hand side of the screen is from a YouTube video that I snagged years and years and years ago. And it was a guy on his 4th day of the job, was using a nail gun. And I would often then ask people, how many people in the audience use nail guns? And a couple people would, particularly out in the rural communities, would raise their hands. How many of you have done this? And a couple people would raise their hands. How many people have done this more than once? 1 or 2 people would do that. Really common for people who are using nail guns. And this was actually not the only time that this guy had put a nail through his thumb, although it was the only one I have a video of. And what was really just funny about this video is he did this and then somebody's recording it. And then this is like a construction site and these are all kind of giving each other a really hard time. And they're like grabbing it because what they're trying to do is pull the head out so they can cut it, so they can pull the rest of the nail through his thumb. And he's like, ow, ow. And he's like, you big baby, relax. It's not a big deal. And they cut the nail out of his thumb. Now, so he's experiencing pain. He did not receive fentanyl. He did not go to the emergency department right then. I don't know. Hopefully his tetanus was up to date. But what he had was tissue damage. So tissue damage, not as much pain, no tissue damage, lots and lots and lots of pain. Now, are these examples of acute pain or chronic pain? Acute pain. And I want to I'm trying to make this really, really clear, because a lot of times people will go through my talks and they say, oh, Dr. Cuccaro is saying this is this and this and this about chronic pain. No, I'm saying this. And as we go through, this is about pain, period, acute or chronic. It doesn't matter. The same principles apply. So then we look at the x-rays. None of you, I think, are radiologists here, but this is your low back and this is your spine. And as you can tell, they don't look the same. And they should kind of look similar. The image on the left-hand side of your screen, that's what we call lumbar scoliosis. That's the curvature that you see. And then in the image on the right is someone's spine. And the darker it is, the more kind of bone mass is in that area. So you can kind of see that this is not 10 years old. And they got some changes around some of the joints in the low back, but pretty normal. And again, most people would look at this and, well, that scoliosis, the person with scoliosis, they must be experiencing back pain. And this particular person was not. It was a 65-year-old woman. You're going to have lots of people have scoliosis. Scoliosis has really poor correlation with pain, and she had no back pain. Well, the image on the right wasn't my patient, but reminded me of a 29-year-old kid that I was seeing when I was in the military. He was on high-dose opioids. Really no inciting event, but just said his back kind of went out one day on the boat and everything was normal. The x-rays were normal. The imaging was normal. Everything's normal, but he had a lot of pain. Why is it? How can we explain that? And we have to be able to explain this in a way that is beyond like, well, this person's lying and this person's not lying and this person's telling the truth. And that one, well, we can kind of trust them, because that's not by science. It's completely judgmental and it makes no sense. So how can we explain how someone can have severe pain and it's real pain? Like, I hate the term, if someone's screaming because they're in such distress, that's pain. So severe pain, but no spike in their foot, chronic spinal deformity, but no pain, little pain, yet they have a nail through their thumb, or normal x-rays, yet they have tremendous amount of back pain. And we have to be able to explain these scenarios in such a way that doesn't rely on saying, well, this person's speaking the truth and this person is not. Because again, very few people are lying when they experience pain. In fact, I can think of one person in my entire career, and I can't say they were, because again, it's a personal experience and only the person who does it, but it had to do with some medical legal stuff. And he was saying, kind of repeating words back to me, and it seems like he was a little bit coaching, and he gave me a little smirk. That's the only thing that I know that might have been it. But the vast majority of other people I've ever met, the most of them have experienced pain, but the big difference is that they don't have tissue damage, and we haven't been able to explain it very well. But if we look at the definition of pain, so the International Association for the Study of Pain, their first definition came out in the 1970s, and it was not much different than this one. Little subtle changes, but it was: pain is an unpleasant sensory and emotional experience associated with or potentially associated with actual tissue damage. And this, so we break this down and we have unpleasant. So nobody likes pain. It's a negative motivator. Nobody grabs a hot stove and holds onto it saying, this feels super good, I want to do it more. No, it makes you withdraw. It's like, or you stub your toe and you pull your foot back. It is unpleasant. It's sensory. So there's some sort of sensory component to it. It's an emotional experience as well. So there's this emotional, what does this mean to me? And it's embodied. We experience this sensation in our body. It is not floating down the hall somewhere. You cannot have pain outside of your body. And it is described in these bodily terms: chest pain, shoulder pain, knee pain, I feel it in my belly, etc. Now we can take this though, and if we update it just a little bit, what we get is that pain is an unpleasant sensory and emotional bodily experience, again, embodied, in response to perceived danger. So it's not damage that is the primary driver when it comes to pain. It's this danger component, this threat component. And so this starts to make sense, because when you understand pain and what is it trying to do, is trying to protect you from harm. So it's either trying to protect you from potential harm, or if you are harmed, is trying to protect you from further damage, or more importantly, when you start involving a evolved brain, is trying to protect you from future harms by the experience that you have now. And so the first fundamental shift is to make when it comes to pain is just understand that pain is not about damage. It is not a damage indicator. It's a danger indicator. Now, what that means is you can experience pain without tissue damage, to kind of cleave this idea that if I hurt, there must be damage. So it's, I am hurting. Is there damage? And when we start explaining it in this protective terms, then things start to make more sense. So if you had a steel-toed boot, what is a steel-toed boot designed to do? To protect your foot. If you look down after you hit your foot on the ground, you have that sharp kind of sting when you jump off or hit off a couple of feet when you smack into the ground with your feet. And then you look down and you saw that spike going through that boot. What would you be thinking? I'd be freaking out for sure. Now, here's another interesting, would there be sensations involved with this? Would they be different sensations than your foot was typically sending up to your brain? And the answer is yes, because there is now something between your toes. That's a different type of sensation. We wouldn't necessarily say that that is horrible sensation, but it would be different, a significant change with a lot of threat that's associated with it. And on the other hand, if you've ever had a hurt, if you've ever had a hurt, not the best English there, and you've recovered from it, and then you hurt yourself again, and the entire process wasn't too traumatic, what tends to happen if it occurs again? It's not as threatening. So these guys who are putting the nail through their thumbs with these nail guns, and they do it, and they potentially can do it again because it wasn't super threatening. And in this particular situation, when you have people around you, when you don't know what may be going on, and they're like, ah, big baby, it's just a nail through your thumb. I did that 16 times over the last 25 years. There's not a lot of threat and danger. And so what we see then is we adjust this danger, this threat element, the amount of experience or the experience pain goes down. And this has actually been demonstrated in many different ways, experimentally and not experimentally. How many of you have ever had a bruise that you don't know where it came from? That's tissue damage without pain. And more than likely you banged your ankle. I tend to do my shins. You may not even notice it at the time. Maybe you were rushing somewhere, but then you find this bruise later on because there was tissue damage, not a lot of experience of pain, or such a subtle amount that it didn't lodge into your memory. Life or death events. Again, we have to be able to explain the spectrum. I was a military physician, and what never made sense to me is how in the world do people get shot or even lose a limb through, say, an IED, and yet they don't experience pain then? And people will go, well, oh, it's the adrenaline. I'm like, well, that guy with the nail through his boot had a lot of adrenaline going through his bloodstream. So there's got to be something else involved with this. And when you think about it in damage terms, it makes no sense. If pain equals damage, and the more damage you have, the more pain you experience, which is not true across the board, but we want to believe it's true, that wouldn't work. So we can't explain it. But if we talk about protection, now it starts to make sense, because if you are in a life or death event and your brain is seeing bombs going off and bullets going everywhere, and if you make the wrong move, you're potentially going to be dead. What does pain in that moment become? Does it become a protector, or would it be a distractor? It would distract you from the actions that you need in order to preserve your life. This is really, really important. Now, we're not in war zones, most of us, most of the time. But if you're ever crossing the street and you twist your ankle, or God forbid, you not only do that, you twist it so bad that you break bones. Maybe you have a trimalleolar fracture in your ankle because you hit the pothole wrong. Typically, you would experience some pain. But if it wasn't this dynamic when it comes to threat and protection, if a bus was coming straight down at you, what would you do? Well, our brains are beautiful, because in that situation, they say, bus more dangerous than my leg. I'm going to get out of this hole and I'm going to get across the street as fast as I can to protect myself. And then, interestingly enough, you may or may not experience more or less pain afterward. It would all depend on other variables. If you didn't have this, though, if you'd had that damage, you wouldn't be able to do the actions that you need to preserve your life. So it's this threat perception. Other ones that they did experimentally are around beliefs. What you believe to be true about pain and the reasons for it actually impact the amount of pain that you experience. So one of my favorite studies, they took hot and cold metal bars. They took a bunch of people and they said, we're going to put these hot metal bars against your body. Tell us when they're too hot, and then tell us when they get too painful so we can remove them. And what they discovered was that hot metal bars, unsurprisingly, are uncomfortable and become painful very, very fast. Amazing, right? And then they took the same group and they said, well, thank you. That was interesting. Now we're going to take freezing cold metal bars and we're going to do the same thing. Take these freezing cold metal bars, put them against your body, tell us when they're uncomfortable, and then tell us when they become too painful and we'll remove them. And what they found there was that freezing cold metal bars are also uncomfortable and also become painful, but they're less uncomfortable and they become painful less fast than hot burning bars. Except for the bars in both scenarios were the exact same temperature, really, really, really cold. And all they were doing then is changing that variable of, this is a burning metal rod, this is a freezing metal rod. And we have learned over time that burning things tend to be more dangerous than cold things. And so that impacts then our experience of pain, because that perception of danger. And then pain without damage. We've talked about that, where you have a significant degree of threat and potential injury and a lot of pain. Guy with a boot, boom, nail through his boot. Lots and lots and lots and lots of threat there. No damage, lots of pain. If you expect something to be dangerous to your body, lo and behold, you tend to become very protective of your body and actually experience pain faster and more severely. So if you are walking, say, we're going into the summertime, there's a pool. Someone's out there with glass that they're not supposed to have. They drop it. It shatters across the ground. You look across that field of glass and the only way to get to your sandals is to navigate that field of glass. What are you going to be very, very attuned to as you tiptoe through that glass field? The sensations through your feet. So you may step on something that may not damage your skin, maybe a sharp pebble or something, and your experience is going to be very different. You're more likely to be very attuned to your feet. Vulnerable expectations. Another study, they told people, hey, we're going to shine lasers on your foot. And by the way, this area of your foot is very vulnerable to lasers. And they found when they did that and they changed that little simple word, they experienced pain faster and at greater intensity, versus the people that they shined the same laser on, the same area of the body, and they just told them, hey, we're just going to shine a laser on your foot. So this change in perception, this expectation of harm or vulnerable expectation, impact the experience of pain. And then, as I said, kind of the belief of harm. Now, this becomes very, very important over time, because if we're looking at, well, why do we experience pain is to protect us. Well, and pain can protect us in the moment. Say you have actual tissue damage, sending signals up to your brain. Now we have lots of threat and danger. There's an experience of pain. But in an ideal scenario, what those memories do and what we learn over time is we learn what is dangerous in our world so that we can navigate it in such a way to protect our bodies from danger. So what we've learned, what we expect, these vulnerable expectations, what our beliefs about things impact the degree of experience, pain that we experience. And so again, when you have pain, it is not this evil thing trying to be mean to you. It is trying to protect you from something. That something may be in your body. It may not be in your body. It may be in your body and maybe something else as well. It's a very complex process that we'll go into a little bit more. But the first mind shift is to think of pain as a danger indicator. What's the threat, not what's the damage? So how does our thinking change when we approach pain in this way, as instead of a damage indicator versus a protector? Because if you're going, I hurt, or my patient or my client hurts, what is damaged? You're trying to find a cause, a single source cause. When you are thinking about pain as a protector and you're going, well, what is this trying to protect from? You're looking at potential threats. One is a much more broad spectrum way of thinking to identify all sorts of different potential threats. And one is very singular. And if we don't have an answer to that, we get stuck. Because then the flip side of this is, if we can assess pain by thinking of threats versus what is damaged, now if we're going to help pain, it changes how we treat it. Because if you're thinking of what is damaged, the only thing that you can truly do fundamentally to decrease that pain that is oozing like pus out of the damage is to fix the damage. And if there is nothing damaged, the imaging is normal, what do we do? Versus if you're looking at protection and you go, well, what is trying to this protect from? Then it becomes easy. Well, if pain is about threat, what do we do to help someone feel safe? Or how do we decrease this sense of danger and threat? And as we get to the end of this particular presentation, this is really, really important. Because if you're in scenarios where you're not, say, you have a broken bone and you're not an orthopedic surgeon, and we're going, I don't know what to do, there's nothing I can do to help this person pain, I'm going to say, no, you can't. What you can do is help this person feel safe or decrease potential threats, one of which the orthopedic surgeon may need to do to stabilize that bone, but a bunch of other ones you might be able to do. So if pain is about protection, then how does it do that? How do our brains and bodies work in a way in order to protect it through this experience of pain? And again, so we have to address those misconceptions again, because we have to think differently in order to understand how this works. So people will typically say, where's the pain coming from? And people will often say, well, my pain's coming from blah, a bulging disc. My pain coming from the arthritis in my shoulder. My pain's coming from my bunion in my foot. But does this actually make sense, that verbiage? Because if it did make sense, and this is really old thinking, that's Rene Descartes' treatise on man, 1664. And what his theory of pain was, is the fire hit a particle on your body, that's B, that pulled a little tether, little cord. And that little cord went all the way up to your pineal gland in your brain, and then kind of opened up a little hole and allowed your pain to ooze out of your pineal gland. So your pineal gland was like where the pain pus was, right? And we want this to be true. We want to think in causes. And if we had another couple hours, we could talk about why that is, because it's really kind of cool how the brain does that. But when you kind of poke it a little bit more, it doesn't make a lot of sense. Because if pain came from bodily structures, if it oozed like pus out of it, in fact, I want you to use that terminology. Anytime you hear the word pain coming from, just say pain pus coming from, okay? Because if pain pus oozed out of these structures, then the treatment of pain would be super, super easy. X-rays, MRIs, all these imaging studies, they would tell us if someone had pain or not. And it would do it consistently and predictably. We'd be able to simply look at an image and say, this person is experiencing pain and this person is not. Is that true? No. And when we're looking at pain that's been there for a long time, i.e. the chronic pain, it becomes even worse. So this has been duplicated many times now. These are the prevalence rates of these degenerative changes in your spine. This particular study was at people who weren't experiencing back pain and looked at your age. Now, when I started this, I was down in the 4-0 block, and now I'm in the 5-0 block. And if anybody did an X-ray or an image of my spine, which I won't let them do unless I was in a car accident and something bad happened, And then they said, your X-ray, your MRI, Dr. Cuvaro, is completely normal. That would be super weird. That would be like looking at me and having the face of a 7-year-old, right? We get wrinkles. I don't have as much hair as I used to have. My daughter likes to remind me I have these big old deep furrows across my head. Those are normal at being 50 years old. Just like the external factors that we see internally, we also have age-related change. So we all have disc degeneration. I mean, 20-year-olds, 30% of them have disc degeneration. Disc signal loss means that they're kind of losing some water in there, 17%. Protrusions. The protrusions are when we used to typically call those as herniations, herniated discs. Again, a third of my age or more have a disc herniation. And these are people without back pain. So again, if we can identify this stuff, and that was the source of the pain pus, lo and behold, it would make it really easy. Now, the problem with this when I'm speaking with, say, physicians, I'm a little bit more adamant this is because it becomes very, 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 very easy to label someone's pain as coming from normal age-related change, and that can have huge implications for their future. There is a reason that if you get X-rays or MRIs for people who don't need them, they have worse outcomes. They tend to function worse, and they have less or more pain for longer than those who have not gotten the imaging studies. Again, I'm not going to go into why or when you should or should not have these X-rays, but we overdo this stuff and we pay the price. If pain came from, then all we would need to do is cut those pain pathways, block them with drugs, fuse those segments, the surgery, and we would stop the flow of the pain pus. And most importantly, it would work consistently. So the majority of the time, predictably, we would know up front it was going to work, and it would be sustained. It wouldn't be 4 to 6 weeks, wouldn't be 2 weeks. It would be years and years and years, preferably decades. Is this true? No. What do we do for pain? We order lots of imaging. We do lots of procedures. We do lots of surgeries, and we prescribe lots of drugs. And there is no improvement in long-term prevalence rates with this. We're not seeing people get better. And part of this is this cause and effect thing. Our brains want to perceive things in a cause and effect fashion. They want to see that this is where this comes from and this is where it's going to. Now, it doesn't actually operate that way. And because we think this way, though, we want to understand pain in this way. And then we're like, oh, broken femur, pain. Scoliosis, pain. Nail through his thumb, pain. No nail through his boot. He must be lying. Maybe he's a drug seeker. Normal x-rays, yeah, that guy, he doesn't really want to do his job. Oh, normal legs, horrible leg pain. God, there must be crazy. And it's because we're looking at this as a damage equals pain. If there's no damage, must be something else. And then the current treatment model starts making sense. The thinking is bad. This is how I was trained. This is how I practiced. This is what I thought. And those were the results I got. As an interventionalist, we're always talking about pain generators, where the pain pus is coming from. And the data shows over and over and over again that it doesn't work. And particularly when we look at the risk factors. So maybe then our model needs an update, because again, this is old thinking, 17th century thinking that has got us where we are when it comes to this treatment, particularly with persistent pain. And instead, if we update it with what modern neuroscience shows, maybe this will change. So at the end of the 20th century, Ron Melzack of Melzack and Wall, who published gait control theory way back in the 1960s, which was kind of mind-blowing, very quickly misunderstood, applied wrong, and didn't explain everything. But Ron Melzack kind of took all the literature and started republishing again, and goes, instead of thinking about pain in this sort of gated manner where there's a stimulus that's going through that's getting influenced as it goes up to the brain. Sort of like the pain is going through a signal and then we're influencing the signal. What seems to be happening is in the brain. And this is a complex experience that has both sensory inputs that are coming in from the body, that also is involved with kind of higher centers in the brain that are looking at how do we evaluate the cognitive evaluative aspect that's looking at how much attention do I need to see? What are the future expectations? What are my predictions about this going to be? And then there's this affective motivational component that's also activated. And what this does is kind of compares it to past experience. What does this sensation mean to me? And so rather than being able to say cause and effect when it comes to pain, we need to start thinking in at least 3 dimensions and to understand the experience of pain. So key concept number 2 is instead of causes and coming from, which is not true, pain does not come from the body, is that your brain constructs an experience of pain from multiple different inputs that are both in the body and within the brain itself. And once we start going, oh, if the brain constructs pain, then all these individual scenarios start to make more sense. Because now there's people who've had broken bones and no experience of pain. There's people who've got nails through their boot with horrible pain. And if we start thinking about threat and then we start thinking about all these other variables going on, now we can say, well, there's all this complexity that's involved coming together to construct or to not construct an experience of pain. And now we're not saying this person's lying and this person's not, and this person's this. So how the brain constructs pain. If we go back to that definition, unpleasant sensory and emotional bodily experience to perceive tissue danger. And then we take Melzak's neuromatrix theory. And I've kind of highlighted there's these 3 core elements here that we need to be thinking in 3 dimensions, not 1 when it comes to pain. And we can break these dimensions down kind of fundamentally into the sensory aspect. This is called the sensory discriminative branch that provides localization and characteristics of a stimulus. Is something sharp? Is it coming from what we perceive to be the toe, your knee, your back, etc.? Is it cold? Is it pokey? Is it dull? The emotional aspect, that affective motivational component, is what does this mean? Heavily influenced by past experiences, such that new sensory input can be compared to say, well, this is like the past, this is what it means. So a hot sensation in a situation when there's a campfire would be burning, right? Because maybe when we were little, we touched something that was hot and we burned our hand. The cognitive element has to do with attention. Does it even matter right now? If it does matter, what should I do next? Future planning. Do I have lots of sensations? I'm pretty sure they mean horrible, awful things, but there are bullets flying around my body. Should I be paying attention to this, or should I be paying attention to the actions that I need to take? And so then when we're thinking about pain, we have to think in 3 dimensions, not in 1 dimension. And this can be very, very confusing to some people, because 3-dimensional thinking is not something we typically do, right? We're thinking about cause effect. I poke you with this hot knife, pain's coming from it. Doesn't work like that way. But how do we think in these 3 dimensions? Luckily, there's a group of people who are really, really good at this. And they're not the plumbers, right? Nothing against plumbers. Plumbers are great. Plumbers are thinking about flow. But we already kind of established that pain doesn't flow. Firefighters, though, think in dynamic processes. And my small little contribution to this whole discussion of pain has been that if firefighters then, they understand that all fire is a constructed process. It's dynamic. It can change quickly. It's 100% real, but it doesn't have, this flow to it. It's basically 3 pieces coming together to construct a fire. You have to have a fuel source. You have to have an oxygen supply, and you have to have a heat element. And it's only when you have all 3 of those that you construct a fire, that dynamic process. And fires change, and they can change very, very quickly. Because if your heat, your oxygen, or your fuel, or all of them change at once, these contributors, as those contributors change, then the fire itself changes very dynamically. Pain is very similar. Pain is not like a river or flow or, what a plumber would be working like. It is like fire. And now we have 3 dimensions that when you put them together, construct an experience of pain, a very dynamic experience. And we have that sensory aspect, those sensory inputs going up to the brain that provides a fuel source. We have the emotional component that provides the oxygen. What does this mean to me? And we have that cognitive element, that attentional aspect that's the heat element. And it is when you have those 3 come together that experience changes. And as we change these contributors, any or all of them, we change an experience of pain. And instead of thinking about causative factors when it comes to pain, we should be looking at, well, what is contributing to this person's experience of pain? The critical point, though, being is that potential fuel is not the same thing as a fire. So we have wood, and we can call that firewood, but we're not scared to touch it because we know it's not going to burn us. And we're not going to throw water on it. And we're not going to throw, have a the firefighters dump like all that red stuff that they dump all over the fires, because it's just firewood. It's just potential fuel. In the same way, things that we see in the body are simply potential fuel. They are not pain generators, and they are not pain. They're just potential contributors, whether it's degenerative changes or a broken bone. This is not where the pain is coming from. That broken bone is sending signals up to the brain that provide a fuel source for a potential pain fire. Now, people say, well, God, you're ignoring the body here. And I'm never ignoring the body. These bodily structures are important with or without an experience of pain attached with them. If you were an ER doctor and somebody walked in and said, man, I fell off a building, and you did an x-ray and you saw that's the femur. It's the strongest bone in your body. And that is a displaced fracture. And they said, and then you're like, oh my God, you got a femur fracture. This is a big deal. We need to take you back and fix it. We have to actually attach it so that it's not running around like that, because it's so dangerous. It can slice your femoral artery and bleed to death very, very quickly from this. But the guy goes, I'm not having any pain. I can just leave. I'm just going to go out. I'll just limp a little bit. You wouldn't do it, because you're not going to ignore that's there just because they're not experiencing pain. You are going to address that broken bone, whether or not they're experiencing pain. In the same way, though, if somebody comes in and is having horrible, horrible leg pain, and the imaging is, quote, normal, you're not going to chop their leg off. Now, we actually have done that, by the way, and it doesn't work. Instead, because it must be coming from the leg. That's where they're having their pain. So we're going to chop off where the pain is coming from. And lo and behold, didn't work. Then they get up with phantom limb pain and have all sorts of other problems associated with it. What we need to be looking at is, what are potential contributors? What other contributors are there, and what may be? So we're not going either or. We're basically saying and. We're looking at bodily structures. And again, I know you guys aren't as much involved with maybe medical treatment and things, but this becomes important with, say, somebody who has horrible pain, but everything is normal, right? We want to look at what other threats are there. If you are working in hospice, this becomes important because you may have somebody who's got cancer and cancer-related pain. So they may have lots of sensory inputs, but there are other inputs that we can modulate without addressing the cancer structures per se. So we're looking at contributors. And then as an individual, we go, well, what can I impact? What are those contributors can I make a difference in? If I can't make a difference here, maybe I can make a difference over there. So key concept number 2 is to move away from plumber thinking into firefighter thinking. You guys should all be journeyman firefighters when we're done with this. I want you to think of pain in firefighter terms in 3 dimensions, whether it's your pain, your friend's pain, your family's pain, people you're working with. What are the contributors? What's the fuel source? What's the oxygen supply? And what's that heat element that's involved with this? Now, this has a huge impact on then how we help to decrease pain. Because plumber thinking, that causative stuff, it goes for where's the pain plus coming from, makes us think, well, what is damaged? And if we don't find the damage, or God forbid, we say, well, this thing that's actually a normal structure is damaged, and then we start doing horrible things to that, we're stuck. But firefighter thinking, we're thinking about, well, how is this pain constructed? What threats are contributing to this pain that are involved in its construction? How we can then impact it is we can increase inputs of safety and we can decrease inputs of threat. Okay. There are lots of different types of inputs of threat, and there are lots and lots of inputs of safety. There are body inputs. So you have nociceptors in your body that send noxious stimulation to your brain. Nociceptors are not pain receptors. All they are is change receptors, and they send a sharp sensation designed to grab attention. And what we could do if you have lots and lots of nociception, say you have a broken femur, is we can numb up the nerves to supply that. We can decrease that sensory element. If you don't, if you're not an anesthesiologist or you're not a surgeon and you don't have access to local anesthetic though, and we can't numb up those nerves, what can we do to decrease those sensory inputs? We can put a splint so that the leg's not moving. What else could we do if we're way away from society and we think about pain in 3 dimensions? I'm wondering if I don't have a pain triangle there. Well, we can try to change their attention. We could try to help them feel safer. We could say things like, I am here with you. We can say things like, help is on the way. We can have people concentrate really, really heavily on something else, a distraction technique, and say, I want you to stare right here, or I want you to squeeze your hand, and I want you to just look at your hand. And what we're doing when we have them do that is we're directing attention away from the bone that's involved and changing that input there. If you guys are involved with prayer and you're somebody who is of faith, you can have them, ooh, shoot, I did something bad here.
I leaned on my keyboard at exactly the same time, and I thought I did it.
Oh no, that was me. That was me.
You, I know, but it still was kind of funny.
Yeah.
It's like, oh no, what have I done?
Well, it's just me kind of getting into my conversation here. But what the picture of this being is that there are many different things that you can do to decrease the sense of threat.
And that point in prayer is very, very well taken.
All right, so we're right there. And we're going to start this again. Okay. So inputs of safety or inputs of threat. So this last key concept here is, if we've talked about pain is not a damage indicator, it's a protector. So it's a danger indicator. It's a constructed process. So rather than think of causes, we're thinking of contributors, all the potential threats and dangers in there. Well, why is it that people who are undergoing a significant or have had significant trauma in their life tend to experience worse pain? And this comes again from fire science. And why do we have a fire season? I mean, God, it was 3 years ago in Oregon, we had a horrible one. It was horrible. And it didn't happen in January. It happened in August when we have hot, dry weather. And what we know is that there are risks when you have potential fire dangers, right? Heat, lots of overgrowth, dry undergrowth, depending on what the weather is. If maybe you have winds and potential lightning without any rain, there's all these risk factors that help predict when we may have a forest fire. Now, also interestingly, in the environments where they're fire prone, the plants adapt. You have seeds that are activated by fire. You have thermal insulation, like the big redwoods that get really, really thick, that can survive most fires once they've gotten to some significant size because they have their own insulation. They have resprouting, ones that are, again, activated or resprout very quickly. We have prolific flowering in the face of fires, or we have tall crowns, plants that have developed where they put all their important stuff up at the top. So if there's brush fires, that they don't burn away. Key point being is, if the environment is prone to fire, then the plants adapt to live there. In the same way, we know there are risk factors for pain. We can call these pain fire risk factors. There is a small genetic component. there's an epigenetic component. Epigenetic means influence on your genetic code by lifestyle and behavior, not only yours, but your parents and your grandparents. It's probably more important than the genetic component. So what you've learned, those around you, what you're actually, eating, sleeping, etc. Small component though, when we start looking at developmental. If you have childhood illness, like persistent chronic childhood illnesses, or you're subjected to abuse, or you're subjected to a neglect, which is a form of abuse. The earlier that abuse and the longer and the quantity of abuse that you have has a correlation with pain. Adult victimization and PTSD people have more pain associated with it. So and we see this kind of stress element. Early life, more stress. Over time, things change. Risk factors for pain. Now, other risk factors for pain: anxiety, depression, and substance use disorders. People who have anxiety tend to experience more pain. People with depression tend to experience more pain. People with substance use disorders tend to experience more pain. What are the risk factors for anxiety, depression, and substance use disorders? They're all the stuff right here. Other risk factors for pain: what you believe to be true about pain, what you expect to occur when it comes to pain, and what we call maladaptive coping, predominantly what's known as passive coping style. Now, if you think of pain in causative terms, then you kind of memorize these, because I remember learning these back in fellowship, but they didn't make a whole lot of sense other than say, oh, this person has a lot of pain, but we didn't understand why. But when you kind of think about, like, why would pain beliefs impact somebody's experience of pain? And in particularly, you can look at, there's what we call biomechanical pain beliefs, that pain is related to structure. And we have biopsychosocial pain beliefs, that pain is involved with, there's a lot of different contributors to pain. It's typically still understood as kind of biological, mostly biological with influences. But the key point being is, the less people believe that pain equals damage, the less pain they tend to experience and the better outcomes they have. Now, why do you think that may be? Let's talk about somebody who has surgery. If you've had surgery, or you're doing rehab, physical therapy, or rehabilitation for some sort of musculoskeletal thing, if you believe that pain equals damage and you start to do your exercises and you experience pain, what would you typically believe to be true? I am damaging myself. Why would I move? Versus, if you understand pain as a protector and you're in rehab, you may experience some pain. I would actually say, if increased sensations, those sensations may be unpleasant, but you recognize that your body's healing and there's lots of change in information, and your body's saying, hey, we're not quite used to this. Boom, boom, boom. Is this something you want us to do? If you understand, I'm okay, I'm safe, this isn't harming me, you're more likely to continue to do that therapy. So when I was working with physical therapists and they're like, oh, my patients are non-compliant, they don't want to do their exercises, I'm like, that's interesting. What do you think your patients believe to be true about their pain? Because there's a lot of people running around who have back pain and been told that they have degenerated discs and that their pain pus is oozing from those degenerative discs. And if you told them that you need to exercise around those degenerative discs, and then they start experiencing pain, what are they going to believe is true? That they're damaging their backs and they're not going to want to move. Why? Not because they're not compliant, because they're not crazy, right? You wouldn't intentionally move something if you believed you were causing yourself harm with it. So huge impact there. And then maladaptive coping, that you guys know the difference between passive and active-based coping style. So passive means that, there's nothing I can do. You must do something to me, for me, etc. Active coping style is like, what can I do? What are things that I can do for myself? Which one do you think is more threatening? Which one makes you feel more helpless? Passive-based coping style. If you feel that there's nothing that you can do, then those sensations and experiences tend to become more threatening. And interestingly, in high distress environments, just like in high fire-prone environments, the brains adapt. And one of the systems that are involved in your brains that changes with this is something called the endogenous opioid system. We all have natural opioid receptors in our brains and our bodies. That's the why that opioids work. And this system changes. So I'm not going to go into all the details on that, but if we were talking about opioids and the risk of opioids long term, we would go a little bit more. But what we see with these changes is there's changes in the brain's connection and network. So we have all sort of these default like electrical activity in the brain that's firing all the time. And there's a common saying, the nerves that fire together wire together. It's sort of like a muscle. If you fire something frequently, it becomes easier and easier for electrical transmissions to fire that way. Just like if you're doing bicep curls and you're curling your bicep, it gets stronger over time, right? In other areas, make it weaker. And then we see these different neural networks that are involved. The default mode network that has to do with kind of this default background activity that's scanning the environment. The salience network, which is involved with threat detection, that kind of works in the background, like you're driving and you're not really paying attention, but boom, there's a ball rolling out in the street, grabs your attention so that you don't run over the kid who may be running out of it. So these connections and networks start to change. Now that also parallels structural changes. Now I don't think, personally, this is my hypothesis, that the structures themselves don't change on their own. It makes more sense that over time, as the systems change and fire differently, then the structures are going to kind of mirror that downstream, just again, like a muscle group would. So we see changes in the hippocampus. The hippocampus is involved with reconstructing memories. Your amygdala, people say that's the fear center. It's not the fear center, but it's a center in the brain that helps to do that, kind of puts together past experiences with high threat or fearful experiences. So, oh my God, when I was here last time, bad things happened. Now I'm in something similar. Bad things could happen to me. Okay, and that's important, right? It's protecting you. The anterior cingulate cortex, the prefrontal cortex, which is involved with the kind of top-down stuff. These structures start to change as these networks change. Now, the overall reason for this, my hypothesis being, because you don't get studies when you publish them and they say, this is why. You have to take this stuff and put it together in order to make sense of it, is this increases the brain's sensitivity to threat and reactivity to potential dangers. Okay. And this tends to make sense. If you are in a highly dangerous environment, what do you want your brain to do? To be relaxed all the time? Or do you want it to be attuned to a dangerous environment so that it could potentially protect itself? And when we look at how this changes then these areas involved with the construction of pain, well, the cognitive element when it comes to heat, if you have a threat sensitive brain, if you've had these changes that are more reactive to potential threats, we tend to see threats easier. Interestingly, when we have sensations in the body, we tend to perceive those sensations in a more threatening way, as a more dangerous contributor than not. And, if you grew up in, I grew up in Carson City, Nevada. It's a smaller town, pretty safe place. And if we were walking down the street and we heard a bang, you're like, oh my God, someone's car, backfired or something like that. If you grew up in, say, South Central LA, where there's a high related, lots and lots of gang violence, that same sound, you would have a different appraisal to it. And if you grew up in that environment, those sounds are going to grab your attention much easier. It makes sense. The emotional component, that oxygen, that fear and harm association, meaning when something is occurring with that sensation, you're more likely to perceive that this is really dangerous. That my body is going to be damaged, or there's going to be more danger. There's going to be more bad things that occur with this. If you've been in a horrible environment with with violence and trauma, what tends to have, what has historically occurred to you, particularly when you were helpless, if you were a child? Bad things. So to prepare you, it says, this is bad. You're probably going to have really bad stuff occur. Increased fear and harm association. It also changes our emotional reactivity and decision-making. Now, why would that be? And specifically here, we start to think in short term, not long-term thinking. Do you guys know about the marshmallow study that they did years and years ago, where they took these like 4-year-olds at Stanford and they're like, okay, we're going to put this marshmallow, and they left them in a room with a marshmallow, which is like a 4-year-old, 15 minutes at times, like 5 hours. And they said, if you don't eat this marshmallow, then by the end of 15 minutes, we're going to give you 2 or 3 or something like that. And they videoed him. And it's, I mean, you can find the videos online. It's cute. These little 4-year-olds, and they're just trying to do all this stuff, trying not to eat the marshmallow. And some of them, as soon as they, the instructor left the room, they just grabbed the marshmallow and shoved it down their mouth, right? And what they found over time is those 4-year-olds that could inhibit that reactivity and actually do more of a long-term thinking. Think, 15 minutes from now, I'm going to get 2 marshmallows if I don't eat this one now, tend to have higher levels of success. They had higher socioeconomic status. They did more things in their career. They had all this good stuff occur. And those that had poorer emotional control tend to have not as great outcomes associated with it. And that got a lot of press for long periods of time. But then they did similar studies with a different demographic. And then it starts to make sense. If you are from an environment with high degrees of trauma, and someone says, I'm going to give you this marshmallow now, but if you can wait 15 minutes from now, I'm going to give you 2 marshmallows. But your experiences has been that you wait 15 minutes, and instead of marshmallows, they give you a slap in the face, or they take something more from you. What is the survival benefit? What would you adapt to do? Increased short-term decision-making, because what I have now is better than the possibility of waiting for something that in my situation is more likely not going to occur. So it heavily impacted there. And then from the sensory aspect, that fuel source, we have nociceptive changes. Nociceptors, again, are not pain receptors. They're change receptors. They're damage, or not damage, they're danger indicators. When tissue thresholds change, they send information up to the brain that basically says something is going on down here. And they're temperature related, they're pressure related, and they're actually chemistry related. They're the things that keep you from getting pressure sores on your butt. Like, I've been speaking for over an hour now. Your butts are probably getting you to shift a little bit, because if you sit in one place, you start changing the environment. That sends chemical nociceptors to the brain that gets you to shift to restore some blood flow there. And what we see is there's some changes, particularly in the brain and the spinal cord, that get more reactive to those change receptors. In addition, there's other sensory inputs that go up to your brain. Interoceptive, which gives you internal state, like how you're feeling. Do you have butterflies in your stomach, or is your heart pounding? Exteroceptive, so those are the sensations coming from the external environment, include things like sight and sound, et cetera. Proprioceptive had to do with your space and movement in space, your body's movement through space, allow you to like give you water to your cup. And these things change. And so what trauma then does is it changes like this heat and element. It provides a very hot, dry environment such that we need very, very little fuel in order to construct an experience of pain. It's just like having, out in Oregon in the middle of August, hot, dry weather. So small little things that typically wouldn't burn can burn now. And anxiety and depression. So anxiety, I see it as a heat element where you're grabbing lots of attention. There's all this threat, potential threat. Depression, I see more as that oxygen supply, where there's lots of fear and harm. This is going to be bad. This has always been bad. We're going to react in such a way that this is bad and there's nothing I can do for it. How we believe about pain, again, that I believe pain equals damage. So if I'm experiencing pain, then that's more damage, increases lots of heat. Our coping style, all these things increase this heat and oxygen that is in our brains, makes it more likely to take the sensory inputs, whether it's normal sensations versus change, like nociceptive information, to construct an experience of pain from. So if you were a firefighter now, and you're approaching pain in this way, not thinking in plumber terms, and you're saying, well, okay, this is the fire, this is the contributors. They have the sensory aspects, they have all this past trauma, they have all this anxiety about what's going to happen next. They have all these external stressors. Where would you want to start targeting your interventions? You're going to target the big threats. Now, if you can't adjust the sensation, what we're going to do is we're going to touch the heat and the fire elements, right? We can identify what those potential threats are and minimize them as best that we can. And lo and behold, the little information, the studies that we have, when people's pain beliefs change, as we decrease that biomechanical, that pain equals damage, people tend to get better. As we change their coping style, or they can change their coping style from, you must do this to me, to what can I do for myself and how can I do it, people tend to improve. As we improve a person's sense of pain, self-efficacy is a confidence that you have agency over yourself, and we increase that, people's pain goes down. And as we increase a sense of perceived control, again, perceived control and self-efficacy are highly intertwined, but this idea that I have control over my environment, or I have control over my experiences, people can get better. And then the big one is psychological distress. So stress, there's distress, threat perception-based stress, and there's eustress, challenge-based stress. Both types of stressors have a hormonal response in your body. Eustress typically has more adrenaline. Distress, the threat stress, has adrenaline plus corticosteroids released. And if you have somebody who's under a significant amount of distress, does that make people's pain get worse? Yes. So what can we do is, how do we decrease those stress? There's a reason why that you tend to experience a lot of pain when everything else seems to be going wrong. You know, the person who stubs their toe walking up the stage to pick up their $10 million Publishers Clearinghouse lotto check tends to not experience a lot of pain after that. If you stub your toe, though, going to your boss's office, and most of you guys are retired, but remember the old days where they were screaming at you, or they're going to chew you out, maybe they were just a big jerk, your day's a lot worse. How about if you haven't slept for many, 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 many days on time? Well, sleep is a recovery system. If you haven't slept, there's changes in the brain and there's changes in the body. That's a threat. I remember, being on call, particularly during residency. And if you're up after roughly 30 plus hours, certainly after 24, you'd start just feeling sick, like ill, and everything's kind of achy. There's a reason for that. Those are a lot of body-based threats, plus the brain's changing as well. So addressing distress wherever there's stressors may be that are contributing to someone's experience. So examples here, and this is it, and then I'll be done. I promise. I told you I was going to go a little bit slow. I see you, Deb, there. I told you it was a little bit slower. Hopefully this was worth it, though. So we look at firefighter thinking with this guy in the boot. And we go, well, what threats are contributing to this pain fire? Are there sensory aspects to this? Yes, there are. I mean, he's got the boot. You kind of think of the inciting event, hits the ground. There's a sharp sensation because there was acute tissue change. Like if you ever, slap your hand against something, there's a sharp sting. Those are the nociceptors in your hand saying the tissues have changed. The tissues have changed, and it grabs your attention. Then you look down and you feel this between your toes. So there are definitely sensory elements to this. The tissue issues imply, though, do we need to do something like fix the toe, chop off his foot, inject it, etc., have surgery? And we don't need to do anything in the tissues per se. We're going to want to pull out that big old thing because you don't want to have that stick between your toes the whole time, but we don't have to do any surgeries or anything like that. What about threat, uncertainty, and anxiety? There's a lot of threat there, a lot of uncertainty. What does this mean? Maybe you watched a documentary on, flesh-eating bacteria. Now he's worried that this is a dirty nail. If they have concurrent anxiety and are already prone to distress because they see a lot of threatened things, more prone there. And then lastly is the emotion, the oxygen. And this oxygen component is based heavily on your past experiences. And this is sort of the individual component to this. What are your previous experience with nails? What are your experiences with steel-toed boots? What are your experiences with your work environment, your family, etc.? Is there a lot of fear, loss, or harm? Does he know somebody that lost their foot because they had a horrible bacterial infection that's going to impact that? Oh my God, John had this and he lost his foot to flesh-eating bacteria. So then we go, well, what contributors can we target? Well, the first one, we cut the boot off, we take the nail out. That's a good one. Can we decrease the anxiety? Yeah, we can decrease the anxiety once we cut off the boot. This is a simple one because you just cut off the boot and you show him his foot and he thinks, oh, I'm going to be okay. This would be like, well, what about the drugs? Were they appropriate? I would say they were appropriate at the time because they calmed him to the point that we could actually ascertain what the potential threats were involved with this foot or not. But we wouldn't continue to prescribe them in this scenario because there's no tissue issues that we need to address. So how can we target those? How about in this particular pain fire, the guy with a nail through his thumb? Tissue issues or no tissue issues? Very easily, he's got sensation coming up to his brain, like we all have sensations come to his brain. But the difference here is there's actually a nail through his thumb. And whether or not he's experiencing pain, we're going to want to take the nail out. This is not a good thing to have. We're going to take that nail out. We're going to want to dress the wound. We're going to clean the wound. We're going to watch the wound for infection. We're going to make sure there's no tissue issues. Another way to think about this is leprosy. You guys know leprosy. Why do people with leprosy, why do they start losing body parts? Because they lose all the small fibers that send the sensations to their brains. There's no fuel anymore. So they tend to get small little cuts and damages. They get infected. Those wounds don't grab attention because we can't feel them. And then the pieces of the body tend to rot off. So that's, pain is important because it's a protector. The absence, because people say, I don't ever want to experience pain. I'm like, you don't want to not experience pain because you won't be able to protect yourself. Okay. So on leprosy, there's no sensation. So there's no fuel source. In this situation, he's got sensation. We can take the nail out and address that. Threat, uncertainty, and anxiety for him, the biggest one is if he had never done this before, remember what I said, what was an environment allowed? Because if you don't know how, if you're in a new situation and you don't know how to behave or you don't know what to expect, what do? We look to those around us and how are they responding? So in his particular situation, he had all his coworkers and they're like, John, not a big deal. Come on, quit, you big baby. We're going to be fine. They minimize the threat in that situation. If you guys are parents, one of the things that, little kids are amazing. They can run around and bounce off things. And really, they only cry if somebody else is crying around that. Like if you go to a playground and they're running and they fall and there's nothing, they haven't really scraped themselves up. What do? They tend to look up, and who are they looking for? And they're looking for what your response is. And if you're generally pretty calm, then they tend to run off and continue to play. And if you're in hysterics, they tend to see that, right? In some situations, we're thinking, oh my God, something must be wrong. And we run up to our children and all of a sudden they start crying because we scared the crap out of them because of that that they don't know what to expect. So in this situation, not a lot of threat, anxiety, and uncertainty there. And then emotion and oxygen, again, that really depends on his past experiences. In this particular scenario, he didn't have a lot of negative experiences with nails, despite possibly doing this before. But if he had, say, lost a previous finger because of a similar injury, do you think this is going to have a heavy impact on his current experience with a similar injury? Yes. So what can we target? Again, tissue issues, pull the nail out, threat, uncertainty, anxiety. How can we calm him? How can we redirect his attention? How can we talk about, decrease the stress associated with that? And all of us can do something there. Back pain, normal x-rays. Tissue issues or no tissue issues? Well, we have lots of sensory input coming from our backs all the time. Anytime you move and their position changing, there's sensory information coming from your brain. But there are no broken bones. There's no infection in the spine. There's no cancerous growths. There's no issues that we need to go in there and cut, fuse, etc. That's really crucial because there's a lot of people who will cut, fuse, etc. normal age-related change because you have back pain. But what you really should be stepping back is if there is no broken bone with instability, if there is no cancerous mass, if there's no bleeding, or there's no infection, then we shouldn't be cutting on these things. Threat, uncertainty, anxiety. Well, if you have a lot of pain and you don't know why, and you've seen 16 different doctors and they all tell you different things, is there a lot of anxiety when you're experiencing your back pain? And if you've been told you have degenerated disc disease and your spine is disintegrating, or maybe you heard disintegrating, because some people don't hear degenerating, they hear disintegrating disc disease. and you had a father that had back pain, and you had a grandfather that had a back pain, and you had people that had 14 fusions in their back and are in wheelchairs. Do you think there's a lot of harm and loss and fear involved with that experience? Absolutely. And where should we be targeting these things? The threat, the uncertainty, and certainly the meaning, what this means. So how do, what do we need to target? Is the big one, particularly for those, is the cognitive and the emotion factor. And then those of you who don't know, we have some really good physical therapists out in here. And what they'll do is they'll help people to actually to feel safe in their bodies again. And they'll help them to feel strong in their bodies again. And they'll kind of rehab them in such a way that we start seeing these beliefs change, that, oh, I'm okay. I can actually move because I am not damaging anything with these actions. How about this one? Broken femur. Tissue issues or no tissue issues? Absolutely tissue issues. This is an emergency right here. I don't care if this guy's experiencing pain or this girl's experiencing pain. We need to fix this because they could die, right? We're going to think in parallel fields. Pain, tissues. Tissues is when we need to do, whether or not they're experiencing any pain. Now, you are out in the middle of the woods, though. They break their leg. You think you can see it all swollen. They can't stand on it. There's no surgeon anywhere close. They're screaming in pain. What do? Can splint it. And this is when your words and your actions and everything else that makes you a good human comes into the key to being a pain specialist. And everybody here can be a pain specialist, is to be a good human. How could you be empathetic? How could you be compassionate? How can you redirect attention? How can you help someone feel safe? How can you help them feel strong? How can you help them that have positive expectations that things are going to get better? How can you use humor in a positive? Humor is extremely positive analgesic. People, when they're laughing, it's very hard to hurt really bad. How can you use all these elements of good humanhood in order to impact those elements while you're waiting to get those tissue issues addressed? And this is one of the reasons I don't want you guys to come away from this thinking that this is about chronic pain. It is not. It's about pain, period. And if you understand pain in this dynamic, constructed way, it doesn't matter whether it's acute or chronic. All you're looking at are what are the contributors and how you address those. So again, I kind of just covered this. These contributors are not specific to quote unquote chronic pains. This is universal. You could use it in the emergency department. You can use it in a chronic pain clinic. You can use it whether you are in a hospital or you're out in the hospital. You can use it for yourself, or you can use it for your family, or you can use it for the people that you work with. These are not specific. Thinking of tissue issues, threat, uncertainty, anxiety, and what does this mean? What is the fear, loss, harm component, and how can I change that? And when we talk about pain beliefs, this doesn't just help in chronic pain, it helps in acute pain. If you believe, just had a knee surgery done and you don't believe that pain equals damage, that pain is just a protector, and you have swelling, but you need to move that joint, it becomes easier to move when you know that your pain is not causing you harm. And again, changing that coping style from passive, what can they do for me, to what can I do, increasing that sense of self-efficacy, perceived control, both of which impact your perception of stress, by the way. So when we have that threat stress is when we feel not in control, or we feel we don't have a lot of efficacy, we don't have a sense of agency, is when we experience lots and lots of distress. So decreasing that distress, changing it to eustress, decreasing those biomechanical beliefs, changing into constructed pain beliefs, and then changing how we actually deal with these things. We're not neglecting and not saying, well, you can't help me at all. We're saying, what can you do? What can I do? What can I expect to get better? And so understanding pain like a firefighter and threats as contributors, how could you think differently about pain, period? To shift that. What potential threats could there be? And particularly different people, like people's pain that you're like, I don't know why they hurt so bad. Well, what else in their life is a potential contributor there? What past traumas or experiences could be associated in clinical work? If you ever have somebody with persistent pain and they go and you go say, well, when did your pain start? Or what's your story? What's going on here? And they go at 1967. In the old days, I said, I don't want to hear. I just want to hear what's going on now. That was stupid. What you want to know is what happened in 1967. That's going to give you huge inputs on that trauma story. They can remember the day the time, and the place, what do you think their brain is doing? Lots and lots of danger with that. That was a hugely dangerous event. The brain says, I don't ever want this to happen again, and I'm going to be very, very protective so that it doesn't occur again. How could pain that didn't make sense make more sense now? When they have normal findings and yet they still have horrible pain, what are those other potential threats? And then how could you think differently about what you do for pain? Again, you guys, as in the work that you do, you have a lot of chance to impact pain as a pain specialist without doing any sort of tissue interventions at all. I would say end of life and pain associated with end of life is some of the most complex pain there may be. You have spiritual pain, that existential kind of pain that's related to it, that emotional pain, the pain of what could have been, past relationships that we may have had, my own relationship with whoever I may believe in or not. All of these things have huge contributors, which you guys that have a huge role in addressing and can make a huge amount of difference in. And you don't have to, again, you don't have to be able to do surgery. You don't have to be able to prescribe medications. It doesn't even really matter to you, because if you can't address those contributors, you look at what you can address. What is your skill set that you can use to help this person to feel safe and to feel more in control? And if you're trying to help them get better over time, how can they feel more powerful, more significant agency and control over their personal environment? And what can we do then to increase inputs of safety or decrease inputs of threat? So challenges, pain's constructive 3 dimensions, but the focus is overwhelmingly on the least important one for most persistent pain specifically. If the pain has been there over 60, 80, 90 days, that sensory aspect and all those interventions become really not useful. Unfortunately, medical treatment is limited. We don't have a lot of good treatments that address that, particularly because that sensory aspect is not the biggest one. When we're looking at kind of the cognitive and emotional elements, those heat and oxygen those chemicals in the brain are very, very difficult to target individually. And you kind of don't want to, because all of those neural drugs affect neurotransmitters, and those neurotransmitters affect many, 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 many different processes and experiences. So they have lots and lots of side effects. Honestly, drugs are easier for someone to prescribe in an office than to have a conversation like we did about pain. So even if you have a good clinician that understands pain, it becomes very, very difficult to have these conversations. And quite frankly, surgery and injections are profitable. There is no incentive to do good pain care in our healthcare system. I hate to say that, but there is absolutely none, because it doesn't make financial sense. When I changed my practice, I drove my income down almost 95% within 6 months. Because I wasn't doing this stuff anymore. And the majority of when you're trying to decide between your mortgage and what's right, the mortgage is usually going to win. And then we have all this misinformation, fear, and false beliefs. I still get Google alerts every week on what's been published recently, and the amount of bad information when it comes to pain is it's unbelievable. Like the stuff people publish out there, it just drives me absolutely crazy. So the reason I started doing these talks years and years ago is the only people who can really make changes, the group. And it's going to have to come from outside the healthcare system realistically, because there's no incentive there. And at a minimum, the more you know, the more you have control over your own experience of pain, and the more you can impact those that you love and the people that you care around you. So just be aware of those. And I'm going to skip that and just say thank you, since we've hit almost 2 hours here.